Hi, my name is Lori Quattro. I am a current student at AT Stills University of Arizona. I am doing a brief presentation this evening on a cardiovascular disease, part of a course of APA 621, instructor Bob McMillan. I decided to discuss briefly this evening and present a case about infectious endocarditis, specifically with an IV drug user. I felt that this was important to discuss this evening due to the increased epidemic of IV drug users, especially heroin use. I've found several articles during my research that has shown, if not doubled, rates of tertiary care with these individuals. So I felt that although this may be something we rarely see, I feel it's going to be something we're going to often see. Infectious endocarditis basically was presented with this 25-year-old female who came in to an ER with fever and arthralgias for about 4 days. As the physician interviewed, she admits to being an IV user, and particularly this injection went into her left femoral vein. After further interview, she is a chronic user of multiple different drugs. Although she denied alcohol consumption, she was an addict of LSD, heroin, smoking tobacco. She's also tried and has used LSD. As she's presenting, she's clearly altered mental status. She's tachycardic. She does have a fever. She also has symmetrical lung crackles. However, her cardiac signs were normal with no murmurs. As we develop a working diagnosis, anything from pneumonia to pulmonary sepsis to infectious endocarditis, we start thinking about these things and what are the criterias that can help differentiate these and to get effective therapy, because we know with infectious endocarditis this could be fatal, left-sided greater than right. However, doing research, right-sided infectious endocarditis is more common, mortality about 5%, where left-sided infectious endocarditis increases to like 20 to 30%. Definitely has a poor prognosis. I feel with any IV drug user that their prognosis could be swayed to the worst. I feel that they are going to have more reoccurrent episodes. As this patient gets worked up, now what is included in the workup? Obviously, we need to have labs drawn, a CBC count, and in that CBC count, there's going to be a white cell count. This white cell count is important to see if there's any shift. Is this viral? Is this bacterial? Also, markers such as CRP, which is an inflammatory marker that also can indicate sepsis. We also do a procalcitonin level. This is specifically for sepsis. Hers actually came back 50% higher, which kind of indicated sepsis. She was also worked up for HIV, Hep C, Hep B, and all these ended up being negative. As we move forward, because these labs end up being a little bit quicker to come back, showing that we probably should start her on an antibiotic, blood cultures are done. The first one you want to do prior to starting the antibiotics, and they are done in intervals, usually intervals of 3, series of 3, usually a blood culture for anaerobic and aerobic. Sometimes you also look for fungal and Pseudomonas and other bacteria, but usually also done spaced apart, usually done in different areas of the body to have the best chance of picking up the bacteria that you're looking for. Often x-rays, also hers showed bronchial pneumonia and pleural effusions. Obviously, something was going on hearing that lung exam and having crackles. She was also ordered to have an echocardiogram. They found 3 vegetations on the anterior tricuspid valve. This is important because it shows that it's a right-sided infectious endocarditis. Those antibiotics are slightly different if it's left versus right. Also with antibiotics here, and we don't have to get into specifics, but you also want to know if the valve is natural or if it's a prosthetic valve, whether the patient has a penicillin allergy or if they don't. And often that dictates to the physician what routes of IV antibiotics that patient should be placed upon. That is very important. Briefly going back to the echocardiogram, some patients do a thoracic echocardiogram versus an esophageal one. The esophageal echo tends to be more sensitive and more specific. I found results from 95 to 100% sensitivity compared to the TTE, which is only about 60% sensitive, except for the esophageal one tends to be more invasive. And if this patient is too severe, they may not be able to go through with having other complications. Keep that in mind when ordering these tests. So this patient was started on antibiotics, and with these vegetations and pulmonary embolisms noted, she probably should have been a surgical case. However, she just did not want, she basically wanted to avoid anything surgical at this point. They did a couple switches of different antibiotics. She was discharged 14 days after her last negative culture. There was no additional follow-ups. I feel that with the indication of surgical intervention and that she signed out early, that this probably yields a poor prognosis, probably a reoccurrence in the future. I just want to briefly discuss too, upon admittance of the ER, in this brief little discussion period I'm going to have, it's very important if a patient presents with a fever and a heart murmur and an IV drug user, you have to expect or suspect, an infectious endocarditis. Most likely right-sided, doesn't rule out left. You have to go through the motions with blood work, with the blood cultures, as well as a TTE or an esophageal echo, a trans esophageal echo. These are very important, along with other criteria. Some physicians use a DO criteria, and in my presentation that I posted for the students to review in the class, I did list those criteria for review. So with this being said, I feel as this epidemic is increasing, our awareness should increase. I think without casting judgment, we should care for that patient and try to get them the best care as fast as we can, efficiently as we can, with the tests that we have available, so that we can reduce their mortality and hopefully increase awareness and help in any way that we can with these patients. So thank you and have a good evening.